Good morning. I'd like to thank the committee for selecting this abstract for presentation. And I'm very excited to present our longer-term follow-up of patients who achieve undetectable minimal residual disease using venetoclax therapy for relapsed and refractory CLL. These are my disclosures. I am an employee at Rolton Eliza Hall Institute of Medical Research, which receives royalty and milestone payments in relation to venetoclax, and I've also received assistance from AbbVie to attend this conference. The disclosures from my co-authors are shown below. So in our study, we aimed to assess a few separate themes of undetectable MRD attainment, specifically its timing, the performance of peripheral blood compared to bone marrow, longer-term outcomes, and clinico-pathological associations with undetectable MRD attainment and recrudescence. We retrospectively analysed 62 patients with majority relapsed and refractory CLL treated with continuous venetoclax at our tertiary centres in Melbourne, and we only included patients who had an objective response. Our cohort was derived from 3 now published phase 1/2 clinical trials, including 14 patients who received concurrent rituximab as part of the phase 1b venetoclax rituximab combination study. Serial MRD monitoring was performed in the peripheral blood and bone marrow using multiparameter flow cytometry, and we used the definition of undetectable MRD at less than 1 CLL cell per 10 to the 4 leukocytes when more than 200,000 leukocytes were analysed. There were 2 previously untreated patients included in this cohort as part of the deletion 17p monotherapy trial. 19 of our patients attained undetectable MRD in the peripheral blood, and 26 patients achieved undetectable MRD in the peripheral blood and/or bone marrow. Towards peripheral blood undetectable MRD, this goal was achieved at a median time of 18 months, and 90% of the peripheral blood undetectable MRD attainment occurred before 24 months on therapy, excluding 2 cases of late confirmation in patients who had not been previously assessed prior to 4 years on therapy. The timing of undetectable MRD in the bone marrow was comparable, also at a median of 18 months, and 94% of cases of attainment occurred before 24 months on therapy, excluding 3 cases of late confirmation in patients not previously assessed. These curves show the landmark analyses based on MRD status at 24 months, which show a significant advantage of undetectable MRD status at 24 months in terms of time to progression and overall survival. In the blue curves, we show MRD status in the peripheral blood, and in the red curves, we show MRD status in the bone marrow. And we observed that MRD status in the peripheral blood was equivalently associated with improved longer-term survival compared to bone marrow. We then analysed putative clinico-pathological associations with undetectable MRD attainment and found that concurrent rituximab was the dominant association, with 64% of patients in the rituximab group attaining undetectable MRD by 24 months, compared to 23% in patients who did not receive concurrent rituximab. Of the 26 patients who achieved undetectable MRD in either the peripheral blood or bone marrow, 10 patients have now recrudesced over a median follow-up time of 24 months. The estimated median time to MRD recrudescence was 46 months, with a lower bound of that estimate at 37 months. We also observed on univariate analyses that abnormalities in TP53 signalling were associated with an earlier time to recrudescence, with a median time to recrudescence of 37 months in TP53 abnormal patients compared to 46 months in patients whose disease did not harbour such abnormalities. And after MRD recrudescence, the median time to IWCLL progression was 17 months, with a range of 14 to 27 months. So in conclusion, in patients who receive continuous venetoclax therapy for relapsed and refractory CLL, we observe that the majority of patients who attain undetectable MRD status will do so within the first 24 months on therapy, that undetectable MRD status is significantly associated with improved longer-term survival, and that peripheral blood appears to be as informative as bone marrow, although prospective clinical trials will better answer this question. We observe concurrent rituximab is the dominant association with undetectable MRD attainment, and that recrudescence is common in this group, occurring at a median of greater than 3 years, and is earlier in patients with abnormalities in TP53. I'd like to thank my senior authors, Professor John Seymour, Andrew Roberts, Constantine Tam, and Dr. Marianne Anderson, our co-authors, and the CLL Global Research Foundation and IWCLL for the travel scholarship, as well as AbbVie for their collaboration and travel support, our patients and their families. Thank you very much.